Hey, everybody. Welcome back to the podcast. This is part 2 of our Sugar-Free MD After Dark series, where I am trying to give you all the information I wish I had had in my 30s about our aging desire. And about how desire and arousal and our anatomy change as we get older. So, this episode is not rated G. So, if you've got littles in the car or wherever you're listening, just be aware of that. It will not be X either, but it is an adult topic, and I will be using real anatomical terms. So, just be warned. This is educational, and I'm hoping really just to arm you to have open conversations with your partner and your doctors, your treating physicians. So for anyone outside of Louisiana, that cannot be me. So, but I want everyone to be able to have this information. So today, what I wanted to, and if you didn't listen to last week's, I would definitely start there because I do think there was some information that will help for this part of the conversation. So the first thing I want to talk about today is I want to start by just talking about how our anatomy changes as we get older. And so the acronym is GSM, is genitourinary syndrome of menopause. And what does that mean? So if I can't really show you an anatomy picture on the podcast, but your urethra, which is your urinary tract, which is how urine comes out of your body, is very intimately related to your vagina. And so if you are looking like north to south, south is the vagina, then we have our urethra where the urine comes out, then we have our clitoris on top of that. So that's sort of your little three parts of the trail there. And so that's what we're talking about, is that entire area. So it's kind of covered by some other tissues that when we are young and have tons of estrogen are fluffy, and they help keep bacteria from getting into the urinary tract, and they moisturize easily, and all of that changes a little bit as we age. And so all of that tissue can get a little bit thinner, it can get a lot drier, and it can become much more easily irritated. Okay, so that's sort of the anatomical change that I want to talk about a little bit. This is important because if we are having pain with intercourse because everything is very dry and we are having moisture issues, that is normal change of our anatomy and our tissues, but there are tons of things we can do to help. Okay, so there are hormonal treatments like estrogen. Yes, estrogen. We can use topical estrogen in that area, in our vaginal vault, and that will help very much replump those tissues. Okay, so if you are looking at stuff on TikTok and you see people using estradiol cream or estrogen cream on their face, it's to plump the tissues, just like it will do for our lady parts. Okay, so vaginal estrogen or topical estrogen can help plump up all of our parts. Now, for moisture issues, and then so we'll go through what all of the hormones do, and they can all help a little bit, but I want to stop briefly and talk about the difference between a vaginal moisturizer and a lubricant. Okay, because we hear lube, and I think these things can get interchanged, and they are not interchangeable. Okay, so lube is short acting in the moment we use during sex to reduce friction. That is a lubricant or lube. Okay, that is during sex in the moment as needed, right? We have that for in the moment. A vaginal moisturizer is like skincare for your face, but we are doing it for our vagina. And that is something that we have to do to maintain. So that is going to be something like an estrogen cream, like a Intrarosa, which is estrogen and DHEA. And that is, and there are a couple of others. And those are things we put on 2 to 3 times a week. And that sort of maintains a healthier tissue balance. Okay. So I do not have all the brand names of things, so I am not advertising any of them. So I am just going to use them in their general terms, but it is something to ask your doctor about if you're interested in those things, because they will have ones that they specifically recommend. And there are different ones that have different pHs and different osmolality and things that, depending on your medical history, might be better for you. So I want you to understand, for the purposes of this podcast today, is that there is a difference between lube and vaginal moisturizer. Moisturizer is a maintenance therapy 2 to 3 times a week, and lube is for in the moment sex to reduce friction. Okay, so hopefully that is helpful. The other thing I just want to briefly say is that our clitoris is not just the little button on the top on that we see, okay, or that is visible. It is actually a very, very large structure, and it engorges with blood flow just like a penis, okay, similar tissue. So when I'm saying last week when I said it might take a little bit longer to get aroused, that's part of it. We need that blood flow to start to plump up our clitoris so that we can have a more pleasurable experience. So a rushing, let's get her done, while appropriate sometimes, depending on time, if you want to have, a fulfilling experience and have an orgasm, you might need a little extra time to get that blood flow to the clitoris. That's all I'm saying. Take it for however you want. Okay. Comfort matters, okay? So this vaginal moisturizer and lubricant, those are important because if we are having pain, remember, our brain is going to shut down the system. So if it hurts to have sex, our brain is not going to want to have sex. Makes sense, right? Of course. It's trying to protect us. So I want you to know the difference between those two things. Okay. Let's move into the hormones because I want to talk about what they do and what they don't do, okay? Because I want you to be wary if TikTok is prescribing you medication. That's all. I'm going to give you real education. I'm going to tell you what we know they do and what we know they do not do. So, estrogen. Estrogen helps tissue, okay? So it can help with the dryness, the irritation, pain with sex related to this GSM, okay? One of the clinical indications for estrogen is GSM. So we know it helps the tissue. It also, so that's localized, right? Systemic, if we take it for our whole body, it can reduce some of the other symptoms of menopause or perimenopause. So for perimenopause, what it can do is level out your estrogen. If you are in perimenopause and your estrogen is starting to decline, your body wants to re-regulate that and it wants to fix it. So it starts spiking your estrogen. And then maybe the next month, your estrogen would have been fine. Then it plummets our estrogen, right? So lab tests for estrogen to determine if you are in perimenopause are not helpful because at any given time of the day, it can be a huge fluctuation. All right. So if someone says they need to measure your estrogen to see if you're in perimenopause, they're a liar pants on fire. Okay. Or as we say in our house, you're a liar and your feet stink. Your estrogen's going to be all over the place. So the symptoms you might feel from that might be changes in your estrogen. So things like your estrogen's really high. Maybe your boobs hurt that month. Okay. Your estrogen's really low. Maybe there's problems with your period, right? So when we start to see those period fluctuations, we used to be regular all the time. Now we're not, or just mood swings. Like, I don't know what's going on. I'm feeling a little crazy. I'm feeling a little all over the place. Like if you're starting to have physical symptoms, my boobs hurt this month. They don't hurt last month. What's going on? That might be a sign that you are in perimenopause, and some systemic estrogen to level it out might help. If you are having hot flashes, we absolutely know systemic estrogen can help. So what does systemic mean? Systemic means we want our whole body to get it, not just our vaginal tissue. So you might be prescribed an estrogen pill or an estrogen patch. Which one's better? Well, it is a conversation for you and your doctor. If you have blood clot risk, you probably don't want to take the pill. You might do something like the patch instead. The patch is like this little teeny sticker that you change out twice a week. Very easy. Okay? So estrogen can come 3 ways, 3 FDA-approved ways. Okay? So bioidentical might mean by a compounding pharmacy that's not FDA approved. We have good FDA approved estrogen. We do not need to use non-FDA approved forms. We have medical indications. You can write a prescription, use your insurance, go to the pharmacy for estrogen. So if we are having GSM or that genitourinary symptoms of menopause, right? We are having pain with sex. Things are dry. We're having recurrent UTIs because our tissue is thinning. That all can use systemic or topical estrogen. So systemic, either by a pill or by a little patch. So transdermal is what we call that. We put a little patch on the skin. It absorbs the estrogen, or so pill, transdermal, or the cream. Okay, and we have a cream that is estrogen and DHEA. We can use that too. There are also lots of non-hormonal prescription therapies that are FDA approved for this as well. Okay, so we have hormonal and we have non-hormonal, and all will sort of fix this GSM, pain with intercourse, and hot flashes and night sweats. Okay, it does not magically fix. This is what estrogen or non-hormonal treatments that will help with the estrogen, what estrogen does help with, will not help low desire all by itself, although it will help desire some. I have patients that are just on estrogen and they said they feel spicy again. Okay, so they don't need man level testosterone to feel in the mood again. So this estrogen can help a little bit. Sometimes just knowing you're totally normal and that you need to start first can also help. It's not going to help your stress and mental load, anything like that. So we have vaginal and systemic. Well, there's also a ring. I forgot. So there's a vaginal ring you can use as well. I forgot. That is an FDA approved one. I might have forgotten other FDA approved ones, and I apologize. I just kind of want you to understand like what it does and what it doesn't do, and that there are FDA approved ways to get them if you have these symptoms. So if you have hot flashes, night sweats, or any of this GU symptoms of menopause, absolutely FDA approved. Your insurance should pay for it. You can get a prescription, go to the pharmacy, multiple different routes, multiple different medications, some hormonal and some non-hormonal, all very effective. Okay, so all kinds of ways to get you what you need if you are having any of those things. Like, we should not have to suffer with hot flashes and night sweats. Like, if you have those things, they actually put you at risk of cardiovascular issues later. Go get medicine for that. Okay, if you are having painful intercourse because everything is dry and friable, go get medicine for that. We don't want that, right? We don't want you to have like 100 UTIs. Like, that is no good. There are urologists out there that will tell you, like, they want everyone, once their tissue starts changing, to be on one of these agents to plump back up that tissue because it can save lives. Like, old people die of urinary tract infections. Anyway, sorry to go on a soapbox. I'm getting off. Okay, progesterone. Progesterone really is used for mood and sleep support. And very important, if you have a uterus and you are taking estrogen, you have to take progesterone. Okay? You have to. Because otherwise, you're going to have just all this endometrial lining growing. It's going to put you at risk for a GU cancer or increase your risk of breast cancer. So if you are on... actually, I take back the breast cancer part, but endometrial cancer, uterine cancer, it will increase your risk if we have this proliferative growth and we don't keep it in check, and the progesterone is what keeps it in check. So if you're on estrogen and you have a uterus, you must be on progesterone. Okay. If you're on a birth control pill, you have these two things already. So if you're on a birth control pill and it's working, you do not need to come off it. Just because you turn 50 or 45 and you think you're done having kids, you can stay on that birth control pill, and that can be your hormone replacement therapy. Just so you know that. You do not have, there's no rule that says you have to come off of it. Okay. So progesterone, a pill most often form. Okay. And it helps with sleep primarily and mood, and protects the uterus. I would say the most important thing is it protects the uterus. But if we are having bad sleep, that's a big deal because it's in multiple areas of our multifactorial desire model that we went over last week. So we want to make sure we sleep. So progesterone, good for sleep. Okay. It's not sexy, but sleep is sexy, right? So we want to sleep. All right. Testosterone. I am not anti-testosterone, and I am not poo-pooing it, but I want you to understand what is true and what is not true, okay? And I'm telling you, we spent a half day on this at the menopause conference with like bench researchers who do the research and who had all the numbers, and so I promise what I am saying is accurate. Testosterone has a place. What it does. If you have hypoactive sexual desire disorder, which is not everybody who like has lost spontaneous desire has, okay, because losing spontaneous desire is normal, it can help you have some increased desire. 100%. Absolutely. So it can help some with arousal and this responsiveness. Absolutely. 100%. There is also a study that shows it can help with immediate recall. Okay. So, and these are at like regular doses that are appropriate for women. So some of your immediate recall. So people have said it does help with brain fog. So it can make us feel a little bit more desire, a little bit more aroused, and help us with our brain fog. Amazing, right? We love those things. It will not fix pain with sex. It will not help your relationship problems, and it will not help you sleep. It also will not do anything for your lean muscle, anything for your fatigue. Okay? Not at appropriate doses. What's an appropriate dose? I knew you were going to ask. I'm so happy. So, the appropriate dose is one standard deviation above the high for the lab that's testing, and they pick those numbers by testing like 20-year-old women. Okay? So, I'm being general, but you can be a little bit higher than a 20-year-old woman, and that is a safe range for women. Man level doses in the 900s, 800, 700, 600. We don't really, like, hundreds are not where we want to be. Man level doses are not safe long term for women. It can cause irreversible changes, things like clitoromegaly, deeper voice, hair growth where you don't want it, weight gain, acne. Okay? So are you going to feel like Rage Against the Machine and like probably amazing? Maybe. I'm not saying that you won't. I'm saying those levels are not appropriate and that they can cause long-term irreversible changes that I don't think most women want. Okay? Most women don't want chest hair in my experience, or a deeper voice, or like facial changes that happen when you're on too much testosterone. So it's not going to help you like get sleep and like not have pain with sex and all the things that these other hormones will do and will help. So it is not magic. More is not better, but it definitely has a place. So again, I'm not poo-poo testosterone, but I want you to understand like what's true and what's not true, and that injecting testosterone is not appropriate for women. So how do you get your testosterone? It's a cream. Okay, that is the most reliable, steady state level, safest way for women to get testosterone is through a daily application of testosterone cream. The caution with that is you want to like not get it on your hands and like be careful not like touch your kids and things like that because it can kind of go everywhere. But that is the safest way to get a bump in your testosterone that is steady state. Not what do I mean by that? You're not getting these huge fluctuations like super, super high, way more than you should have, and then super, super low where you're kind of in the same boat you are now if you think your testosterone's low. Okay. Do we measure testosterone? Yes, we can measure testosterone. It is most useful just to make sure we're not going too high. Okay. So do we even need a baseline? Probably not, but maybe, right? We love baseline labs. We love data as doctors. So maybe baseline labs. And then if you're on testosterone, we're going to check that level because we just want to make sure we're not going too high. Because again, if we are at man level doses, we are going to run into potentially irreversible changes, and we don't want that for our patients. It's just not appropriate. So things like injections, your like the level goes so high, so fast, and then plummets. Even men take it twice a week. Okay. And they like for man level doses. So I have done deep dive research, diluting the testosterone as much as you possibly can. The amounts you would have to inject to have a safe dose for women is so tiny, it would be almost impossible to draw it up in the needle. So tiny. And you'd have to do it every day to have the steady state that we're talking about, or multiple times a week. So if you're going to inject like a whisper amount, a droplet, you're better off doing the cream. And it would be very, very hard to get those concentrations, like to dilute it out the way that you would need to for a woman. Because remember, women are using like one I don't remember if it's 1/10 or 1/100th of what a man should. Let's just say 1/10 for ease. Okay. So 1/10 of the dose. So you do not want to be injecting it. And pellets are something, it is an impregnated, item that goes under the skin that then dissolves and releases testosterone. They are very difficult to manage. The amount is way too high for women 99% of the time, and there is no way to remove it if you have an adverse reaction. So it's like too much, too long, no way to get it out if there's a problem. I am not a fan of pellets. Okay. Again, we have FDA approved testosterone for men. So let's just take women out of it. Pellets are not that. Okay. So we know even for men where we have a lot more room for error in their level, we are not giving them pellets either. Okay. We give them injections. And then we have monitor them closely. They have to get lab works all the time to monitor and measure their estrogen. There's all these other problems. So, it definitely has its place, but if you are a woman and you think you need testosterone, what I highly recommend, and I'm not your doctor, but if I was, what I would tell you is that we are going to maximize your estrogen first because people feel spicier just on estrogen. We are going to give you progesterone if you have a uterus to protect your lining. If you are having pain with sex, we are going to address that with either a hormonal or non-hormonal topical situation so that everything plumps back up and feels better. We are going to use lube when we have sex so that there's no friction. So we take that off the table, that we're sort of having an aversion because it doesn't feel good. So we're going to do all that. Then we're going to talk about all those multifactorial things we talked about. Are you making time? Are you afraid people are going to walk in? Are you carrying too much of a mental load? Are you sleeping well? How's your nutrition? How's your body image? How are all those things, right? And it makes it sound like that's months worth of work. That's one conversation, right? We're going to go through all those things and see if there's any lifestyle modifications we can do. So we're going to do our estrogen and our progesterone for a couple of months. Make sure those are good. We're going to do our lifestyle modification. And then if you still think you need a little testosterone, we're going to do cream. Okay? I guarantee that's how 99% of your informed physicians are doing it. So that would be my recommendation if I was giving you medical advice. That is my educational information for you. Okay? So, more is not better. Women are not tiny men. We are different. We need different things. We need different dosing. But it has its place for sure. So, there are lots and lots of women that are on all three therapies, estrogen, progesterone, and testosterone at appropriate doses and feel great. They've also worked, I promise, on some of the things that we talked about last week as well. So if this was helpful to you, I am going to be putting together a course. I'm doing a couple of in-person events that have been super fun. And I would love questions from you if you have more questions. What I want you to take away mainly from these 2 weeks of podcast is number one, it is 100% normal that your spontaneous desire has plummeted to maybe nothing. That's normal. That doesn't mean that we can't appreciate that there are other reasons to start having sex and then our reactive arousal will jump in and save the day. Okay. So planning sex is totally fine. This open conversation about a desire mismatch, we need to have it. And then hormones 100% have a role if you are dealing with some of the things we talked about. I just wanted you to be informed of what they do and what they don't do and the safe ways that they are prescribed. And again, if you need a menopause certified provider, just look on their website. Okay. We didn't learn these things in med school. It's not our fault. Okay. But some of us have chosen to take this deeper education because there is a need, because there's this whole population that needs to get the best medical care and feel the best in their bodies for as long as they can. So longevity is one thing, but it's really health span where we feel healthy and great for as long as we can. And so hopefully you found some of this helpful. I would love to hear your questions so that I can make sure you have everything you need in the upcoming course, Sugar-Free MD After Dark. We're calling it the new sexy. So sexy changes a little bit, and we're going to be there for it, and we're going to help you through it too. So make sure you email Dr. Stacy at sugarfreemd.com with any of your questions about any of this, and I'm happy to answer. All right. I hope this has been helpful. Please share with a friend or your partner if you want to talk about it and make some plans about how to get that connection. All right. I'll talk to you next week. Bye.